Hello, I'm Dr. Chris Rapoff. I want to thank you for joining me today as we take an in-depth look at the diagnosis-related estimates, also known as the DREs, found in Chapter 15 of the AMA Guides, 5th edition, on spine impairments. First, I'll review when and why as we use these DRE categories, and then I'll provide you with examples of providing an impairment rating in each of those 5 DRE categories. So let's get started. First, I'd like to provide you with the sources that I used in preparing this presentation on DREs. Obviously, the first source is the AMA Guides 5th edition, and the same author also produced a book years later titled Master the AMA Guides, the Medical Legal Transition to the Guides of the Evaluation of Permanent Impairment. And finally, we get an attorney's point of view, some controversies in California workers' compensation rating, case law, the PDRS, and a liberal construction of the AMA Guides 5th edition. Okay, first let's do a little review. Spinal impairment ratings are performed using one of two methods: the DRE, or the diagnosis related estimate, that we will be discussing today, and the range of motion, or ROM method. Okay? So the DRE method is really the principle, the most widely used to evaluate when a person has had a distinct or a specific injury. But when the cause of the impairment isn't easily determined, and then the impairment can be fit into a category of the DREs, then the evaluator should use the DRE method. If you take a look at figure 15.4 on the right of the slide here, first of all, you'll see it's very well understood, obviously, that the individual needs to be at maximum medical improvement, or PNS, or permanent and stationary. If not, you wait for that to happen. If they are MMI, then you go to the next step. A permanent impairment is due to an injury or an illness. A specific distinct injury takes you down the path of the DRE category, as you see the DRE method. If it is an illness, or if it is not absolutely a distinct or a specific injury, then you will use the range of motion method, and that will be discussed in a different installment. So as you can see here, it is cut and dried fairly easily. Now what you need to do, and this is very important, when you are providing your impairment rating for these individuals in your discussion of your report, if you do choose to use a DRE or the range of motion method, whichever one you choose, you need to tell them why you did not perform the other. So if you're using the DRE method, you need to state succinctly why you didn't use the range of motion method, and vice versa. This will make your report substantial medical evidence. It will qualify it for it, and then you can move forward and this won't be a problem. Okay, the DRE method has 5 diagnosis-related categories, and for each of the spinal regions, and we will discuss those, compare and contrast those in future slides here. But when we assign an individual to the correct DRE category, you have to approach it one of two ways. Number one, it has to be based on the symptoms, the signs, and appropriate diagnostic test results. You'll find these signs, symptoms, and diagnostic test results in box 15.1, and we're going to explain those in depth in a few minutes. And also, second, you have to base them on the presence of fractures and/or dislocations with or without clinical symptoms. So if you have a fracture, there is an impairment rating under the DRE category that they will apply to. And then finally, number 3 here is off of number 2. If a fracture is present that places the individual into a DRE category, which it will, no other verification is required. So that's what you need to take into consideration as well. You will get an impairment rating if there is a fracture or a broken bone. So in order to use the DRE method, we need to obtain an individual's history, obvious. We need to examine the individual, review the results of the appropriate diagnostic studies that were performed, and then we were able to place the individual into a category. As you see, the first 3 are very important in the fact that that is a definition of qualifying for substantial medical evidence. If you remember, you obtain an adequate history. You do an adequate examination of the individual, and you review the results of the appropriate diagnostic studies. So as you see there, this is also just another way for us to be sure that we're going to qualify as substantial medical evidence in our report. Okay, before we get in depth into the categories, I'd like to just give you an overview of the DRE categories. As we had mentioned first, there are 5 categories, and they're 1 through 5. Most of the examinees or the applicants will pretty much fall into the first 3 categories, and we'll review why again in a few. Anytime you have an altered motion segment integrity, so that includes either increased or loss of motion, you will qualify the examinee for a category 4 or 5 with no other information necessary. So you can see how these are very important, these altered motion segment integrity x-rays would be, and those are going to be in the flexion and in extension. And you would do that in the cervical, thoracic, and lumbar spine. So also a fracture or a dislocation with or without symptoms applies a category to the individual as well, with no other verification needed. And we'll show you that when we compare the DRE categories. Finally, if the impairment's in different spinal regions, so you have a number of spinal regions, what do? Well, you need to do the same method, either DRE or ROM, on each spinal category, and then you combine the ratings by using the combined values chart. So that's pretty basic. And as I had mentioned earlier, fractures are very important when it comes to DRE categories, and they indicate that even more than one level in the same spinal region, say an L4, L5 fracture, should not be used with the DRE category, but yet the range of motion method. Okay, here's an example of one of the tables in Chapter 15 regarding DRE categories. This happens to be for the cervical spine disorders, but I just wanted to acclimate you to the table itself. First, you'll see that we have a DRE category 1, 0 impairment of whole person, category 2, and so on to category 5. Each has characteristics that you're supposed to look for and qualify this person under each category. So as you can see, category 1 is pretty basic. 2 gets a little more involved, and we'll discuss these as we go along. 3, 4, and then finally 5. And as you see, we go from a DRE category of 0 impairment in cervical spine, category 1, to a DRE impairment of 35 to 38% in category 5. So this is a very important rating mechanism for our applicants. Okay, so let's look at, just for an example, lumbar categories 1, 2, and 3 here. We will discuss them and compare and contrast all 3 spinal levels, but let's just start with this. In category 1, as you see, there are really no significant clinical findings, only subjective findings. So therefore, the individual would qualify as a 0% impairment whole person. Now you move to category 2, which the range is 5 to 8% impairment, and in category 2 they have objective findings, but no radiculopathy or alteration of structural integrity. As I mentioned, this loss of structural integrity will automatically place the person into an either category 4 or 5, and 1, 2, and 3 are even skipped at that point. Now category 3, you must have objective verification for radiculopathy assessment. That's important because we're talking in number 2 that no radiculopathy or alteration of structural integrity, but in category 3 you have to have objective verification, which would mean diagnostic imaging, EMGs, things like that. Now, after reaching MMI, the individual in your office, in your QME examination, may not have objective findings that they had when they were in an acute condition pre-MMI. So you have to keep that in mind. Don't be taken down the road there by understanding how painful this condition was prior to MMI. You are rating that impairment today on the day of your examination, and they may not define a current rateable condition. So keep that in mind. Even though they had substantial subjective findings and objective findings earlier, at MMI they aren't if they are doing well. So the impairment rating is based on the condition after MMI and not the prior symptoms. Just keep that in mind. Now, in a closer look in Category 2 and Category 3, and specifically in the lumbar categories that we're discussing here, there seems to be some confusion with doctors regarding radiculopathy, post and pre-surgical. So we're going to try to discuss this a little bit here, and then we're going to cover some really pertinent examples later in the presentation that will hopefully guide you to making a correct and accurate rating. But at Category 2 individual, so we're discussing Category 2. The examinee, say for instance, has had radiculopathy, and maybe it was due to a herniated disc or a lateral spinal stenosis, but they responded to conservative care and have no residual signs or symptoms. So you would be placed in this category of no radiculopathy, possibly radiculopathy in the past, but it is resolved because remember, we are rating the individual at MMI. If there's no more radiculopathy or radicular symptoms, then that is no radiculopathy and they would go into Category 2. Now Category 3, take for instance the examinee that has symptomatic radiculopathy even after medical or surgical treatment, or another indication where they've had a history of previous radiculopathy caused by what we said earlier, a disc herniation or lateral spinal stenosis, but they have improved or become symptomatic following surgery. So after all of the medical intervention, they then now have become symptomatic following surgery. They would go into a Category 3, and as you can see, 10 to 13% whole person. Okay, again, in the lumbar categories, now we're going to do Category 4 and 5 and discuss those. Category 4, as I had mentioned, that is the big category for a loss of motion segment integrity. And as I mentioned, those are either increase or a loss of motion. These are only found in flexion extension x-rays, so therefore if you're provided an AP and a lateral spot view, you are unable to provide any type of diagnosis with regard to loss of motion segment integrity. Now, if you take a look at the category below, when we discuss fractures in Category 4, if it's greater than 50% compression of one vertebral body without neurologic compromise, they automatically go into a Category 4. Category 5, for people that have radiculopathy and motion segment integrity issues, and they have atrophy or a loss of reflexes and pain, and also dermatomal sensory changes. Remember, these sensory changes must be dermatomal or follow a dermatomal pattern or be anatomic. If it's not, and they just say that they have pain down the leg, or they cannot be specific as to what dermatomal pattern it is, that is what is called non-verifiable radiculopathy, and frankly, it doesn't qualify. Again, here, fractures of over 50% as well, with a unilateral neurologic compromise. So as you see in Category 4, with fractures, they have the more than 50% compression, but no residual neurologic compromise, whereas Category 5 does have the compromise. Now, in the cases where the abnormalities that we previously discussed in the categories, if they present on some imaging studies and are assumed to have pre-existed the injury that is being rated, you should acknowledge these in your report as pre-existing, or I use this term because this is what the guide used, an antecedent condition or coming before. So you need to mention that these pre-existing conditions are what they are, and they were not as a result of the injury that the person is alleging. Now, if you're requested to do so, you may need to assess whether it was previously symptomatic or any aggravation occurred as a result of the injury. These are stipulations that you're going to have to address in the discussion, especially if they ask you. I have a rule of thumb: only answer the question, do not provide any extra information, and if the question is not asked, then you don't need to answer it in your report. Now the guides also gives them some guidance on how to move forward, where we do know we have to document the physiologic and structural impairments. That's understood. But we also need to mention what are called common developmental findings, or I used to call them findings of just getting older. You can find spondylolisthesis in an individual. That would be in an X-ray or an MRI, and that's usually presents in about 7% of the adults. The condition of spondylolisthesis, which is a bilateral pars articularis break, found in about 3% of adults. The herniated disc without radiculopathy, found in about 30% of individuals by age 40 years old. So we're just saying these can present, and we will see these in folks that are age 30 and over. And then also aging changes. That's present in 40% of the adults after age 35, and pretty much anybody over the age of 50 is going to have some degree or some level of degeneration in their spine. So with that said, we have to remember, and this is very important, and it's incumbent upon us to keep this in mind, that these abnormalities that we do see in imaging studies do not mean that the individual has an impairment due to an injury. If these exist, as we've seen in 1, 2, 3, and 4 above, they can exist and coexist. And many times, if I am asked to provide or opine on pre-existing conditions, if the individual doesn't have an impairment due to an injury but does have these abnormalities in the imaging studies, I just say that those are coincidental findings on the imaging, because in actuality they are. It's a coincidence that they happen to have these findings, and also they don't have an impairment. Okay, now let's get to the definitions and the clinical findings that they use to put the category 1 through 5 for an examinee. Here is box 15.1. It's very difficult to read, but I just wanted to show it to you. This appears in 2 pages in the book, page 382 and 383. We're going to go over each of these. There are 12 definitions of clinical findings that we will address. Be interesting to see if you remember all of these, or if this is a good refresher for you. I just want to provide you with some examples of what we're going to be discussing here in the next few slides. Here's an example on the left of a loss of motion segment integrity assessment. This is an X-ray, an extension X-ray, and as you can see, measurements are being made and tabulated. Now, with that said, the exact understanding and way to perform the loss of motion segment integrity assessment is found in the AMA guides. You do need to review that if you are going to provide an impairment rating for them, because it can be a little tricky to provide this information, but it's very pertinent. And as you can see, category 4 is provides a pretty high whole person impairment rating. So if you determine that this individual has this impairment, then it's certainly going to be good for their case. Second, you see the EMG nerve conduction velocity studies. This is when you're looking for absolute diagnostic criteria that will help substantiate your category finding. And also radiculopathy assessment, an example of the dermatonal chart of the upper extremity. Okay, now getting into some of these findings, signs, and symptoms, obviously some are very, very remedial. but it's always good to review, as I mentioned. So the first one we're going to look at is muscle spasm. And they define muscle spasm in the guides as an involuntary contraction of a muscle group or muscles. So what's important here is the involuntary contraction aspect. So you take a look, for instance, at the paravertebral muscle spasm. After an acute injury, that is very, very common. However, it is rare in a chronic back pain condition. So if you have an individual that was originally hurt in 2 years prior and they're coming in for an impairment rating and you see this muscle spasm, you probably need to investigate a little more with the individual to find out if there is some acute issue that has happened, either a subsequent injury or just what is going on, because this should not be there. A muscle spasm is not a chronic condition. And it is involuntary, so you can see and touch this, and this will help you with your understanding and with your determination of muscle spasm as one that applies in the category. Now, in contrast to muscle spasm, we have muscle guarding, and the AMA guides defines muscle guarding as a contraction of the muscle that minimizes motion or agitation of the injured or diseased tissue. In this case, we're talking about the spine. Now, in contrast, this is not a true muscle spasm, and this muscle guarding is voluntary, and it can be legitimate, obviously, but you have to be careful since it is voluntary. That adds some subjectivity to the realm here. And also in the lumbar spine, contraction can sometimes result in the loss of normal lumbar lordosis. When does this become important? Well, when you receive your diagnostic imaging reports, and they are many times stating, especially in the lumbar spine, loss of lumbar lordosis, probably or possibly due to muscle spasm. Okay, so they say spasm or a muscle guarding, but this will actually help with your category placement as well. Now we come to asymmetry of spinal motion, and this may be confusing for you to think that, well, you're curious as to why this appears in the DRE categories, as asymmetry of spinal motion generally refers to loss of range of motion, which would be the range of motion method. However, if you do recall, when we are placing an individual into a DRE or a range of motion category, the suggestion is that we perform both methods, and the method that provides the highest impairment for the applicant is the method that we use, provided they fit the criteria. For example, specific injury versus an illness that we discussed earlier. So as you see here, they're using the dual inclinometers in the thoracic spine, and what they're looking for is a muscle spasm or guarding that creates some asymmetric motion, either in flexion, extension, lateral flexion, or in the cervical spine, you also have rotation. So to qualify for symmetric, asymmetric motion, it has to be reproducible, and obviously it has to be consistent. So there we are. That's why we perform these movements or these measurements 3 times after we provide the 3 warm-ups prior to the examination of that body part. Now also you have to be convinced that the examinee is being cooperative and giving you a full and sincere effort. If not, then malingering comes to mind. But checks and balances, it appears, is in the lumbar spine, they have the validity test. This is important because the sum of the flexion and extension angles of the sacrum should not be more than 15 degrees more than the tightest SLR, or straight leg raising. So you want to review that and make sure you do indicate that in your report, and indicate whether or not you feel that the examination was valid. If it is valid, then you have a good, cooperative, credible testimony or a credible applicant examinee. If not, then there seems to be some question as to whether or not their validity would come into play, and maybe malingering would be something to consider. Okay, let's once again touch on non-verifiable radiculopathy. It's defined by the guides as a pain that is in the distribution of a nerve root, but no identifiable origin. And what does that mean? Well, if they have a dermatomal pain, for instance, an L5 dermatome, pain that goes to the lower extremity, however, it is not identified as a diagnostic issue, meaning on imaging studies there's no lateral recess impingement or there's no herniated disc, that would be determined to be a non-verifiable radiculopathy. Now, there are no objective findings, so you will not find any positive findings doing sensory testing. There's no imaging findings I mentioned, and or electromyographic findings. They are all negative as well for a nerve injury. But what is very important here is there needs to be a dermatomal pattern in the pain. Otherwise, it's basically a subjective complaint without an objective finding, and it's not considered an injury, would not fall under a category 2 under non-verifiable radiculopathy. All right, now I wanted to bring out something that is interesting in the lumbar category 2, as described on the right-hand side of this slide. And I highlighted it in orange. But let's talk about, as a review, we have a requirement that in order to be in a DRE category for non-verifiable radicular root pain, it has to be dermatomal in origin and have an anatomic distribution, understood. Now, also we said there should be negative diagnostic findings, so negative EMG, NCV, MRI for herniated disc or lateral spinal stenosis. Also, a lack of objective clinical findings, so there are no atrophy, no reflex loss, no sensory or motor issues. So that's your category 2. Now, in box 15.1, which are the listings of the symptoms and signs that we're discussing and findings, they refer to the non-verifiable pain in the three DRE tables. Category 2 lists them as radicular complaints. Why is that important? Well, they're defined in the complaint is defined in all 3 tables as pain and not numbness. See, so if you understand, if they're talking about radicular pain, non-verifiable radicular pain, then there's where you would fall into category 2. Now look at if a sensory loss occurs in the dermatomal distribution, but no objective findings, it would also satisfy at least DRE category 2. So as you see, when you don't include numbness, then you have the sensory aspect that comes into play when you're doing your rating. And in this case, they could qualify at least a category 2, if not more, with sensory issues. And if there are enough radicular signs and radiculopathy signs, then you could increase your rating to a category 3. But be sure to follow the rules. We talk about reflexes now. Pretty obvious, pretty straightforward, but there are some nuances that you want to consider. First of all, your reflexes are going to be one of 4 things. It's going to be either normal, increased, reduced, or absent. For these reflex abnormalities also to be considered valid, the involved limb, whether it be the upper or lower extremity, should have some marked asymmetry between the arms or legs in the repeated testing. And this refers to if you do find a discrepancy between say for instance, the lower extremity versus the upper extremity, and you find a discrepancy in the reflexes of left to right, you want to repeat those periodically throughout the examination. You know, the examination can take several minutes to even an hour. So if you do notice that there is a discrepancy, you might want to repeat it later at a later time during the examination so you know that it is indeed the case. Now, you also want to keep in mind that once this reflex is lost due to a radiculopathy, the reflex very rarely returns. Okay, so you're not going to see a normal if they have lost it previously due to a radiculopathy. And then also the abnormal reflexes like the Babinski sign or clonus can be signs of a cortical spinal tract involvement, and those categories and rating those are also in Chapter 15 after the range of motion method. And now we come to weakness and loss of sensation. So now you're looking at motor and sensory aspects of this dermatomal issue. First, you see the individual is undergoing an examination, a sensory examination using the Sims-Weinstein monofilaments, which we all should have. And you find that these sensory findings, as I mentioned before, they need to be in an anatomic distribution or have a dermatomal pattern to them. It cannot be nondescript. It cannot be my whole leg hurts. It can't be that situation. In order for it to be considered in a category, it has to have a dermatomal pattern. Now, also with sensory, in motor, your motor findings should also be consistent with the affective nerve structure. For instance, you have an L4 sensory loss or a loss of reflex, then chances are you're going to be doing your motor examination and you'll find that the quadriceps on that ipsilateral side is weak as well. And also you'll see C5, C6, you're looking at biceps, triceps issues in the upper extremity. And this is also usually accompanied by atrophy. So these are not absolute, but if you're going to have radicular symptoms, generally there's nerve issue that has caused damage. Generally there will be some decrease in circumferential measurements, which we'll discuss here next. Now we come to atrophy, and it's measured with a tape measure at identical levels on both limbs. And these identical levels are defined as from the center of the patella, approximately 6 inches, and distally 6 inches. And in the upper extremity, from the center of the olecranon process, approximately 4 inches, and distally 3 inches. And those are measured bilaterally. Now, the difference in circumference is where the issue comes in. If you have 2 or more centimeter difference in the thigh compared bilaterally, that is considered atrophy. If it's 1 or more centimeters in the arm, forearm, or leg, that is also considered an atrophic limb. And you can address the asymmetry also due to dominance, meaning you are going to expect the extremity on a right-handed person to be slightly larger than the left-handed person. So there's your dominance. Not necessarily absolute, but it does happen very often. As far as dominance in the leg, very difficult to know what leg dominant you are. So if you have an individual that's very active, I will usually ask them when they kick a soccer ball or a ball, what leg do they normally kick with? Or if you visualize a person walking up the steps, many times the dominant leg or the dominant lower extremity will be the first leg that goes on the step, whether it be the right or the left. Now, you know, a picture is worth 1,000 words. So if you see 2 centimeter difference or atrophy in a circumferential measurement of the thigh, it's going to be visually apparent as well. Why don't you take a picture and insert that picture into your examination? Again, this just gives you more credibility, that you know what you're doing, and it also, you are utilizing the tools that are available to you in order to get a more accurate rating. And I think everyone in the long run will be happy with that. Now we come to radiculopathy. In contrast to non-verifiable radiculopathy, this would be verifiable radiculopathy. And for the purpose of the guides, radiculopathy is defined as, and I'll read it here, a significant alteration in the function of a nerve root or nerve roots, usually caused by pressure on one or several nerve roots. Again, that sounds very easy. Let's move on. Diagnosis requires a dermatomal distribution of pain. We know that, and that's the non-verifiable as well. However, here you can experience numbness and or some type of paresthesia in a dermatomal distribution. Again, what is important here? A dermatomal distribution. If you have paresthesia or numbness in a non-related area or in a non-anatomic area, that is not considered a radiculopathy. Also generally present is the root tension sign. You would see a positive root tension sign as well. And if you are going to determine that they have a herniated disc, this is not just substantiated by their examination findings. You must have it substantiated by a finding on imaging study. That's very important. Now, as I have in remember below here in red, the presence of findings on an imaging study does not make the diagnosis of radiculopathy. So you have to have more evidence than just an positive imaging study. In other words, you're going to need more clinical evidence of possibly atrophy, loss of reflexes, something that substantiates that and not just the MRI. Again, we come to radiculopathy and some misconceptions and misunderstandings, and so I will try to highlight these as well. But again, radiculopathy has been defined as an alteration of the function of a nerve root. Okay, we know that. So there is some damage to the nerve, which is important when you're trying to discern between non-verifiable radiculopathy and true radiculopathy. The misconception is that radiculopathy is just pain and in the dermatomal distribution. Well, that's the definition of non-verifiable radiculopathy. So see what I mean? We need more information. We need more positive findings in order for us to change category to a verified radiculopathy. And that will come in the way of finding sensory and motor loss, possibly, or atrophy, reflex loss, etc. So we do need the radiating pain or numbness, and then you also need some other factor included in order for it to be a verified radiculopathy. But again, we have to keep in mind both radiculopathy and non-verifiable radicular pain must be in a dermatomal distribution. Otherwise, that finding is basically a coincidental finding that does not apply to the categories of the DRE. Now we come to electromyography, or the electrodiagnostic verification of radiculopathy. When we're discussing this, the electrodiagnostic evidence of an acute nerve pathology generally will include the presence of multiple positive sharp waves or fibrillation potentials. And it has to be in the muscle innervated by one nerve root. So again, we're getting the dermatomal distribution pattern that needs to be here when we go into DRE category rating. Also, the guides makes a very strong argument that correct interpretation of the testing is essential, and basically telling us that it depends upon the reader of the test, the doctor reading the test, if they have experience versus lack of experience, things like that. So there is some subjectivity just due to the reader itself or the interpreter. And the electrodiagnostic verification also can detect non-compressive radiculopathies, which aren't identified by imaging studies. And this is important because taking into consideration where electromyography is very important, and a defining diagnosis would be for carpal tunnel syndrome. You're not going to find a whole lot in imaging studies, but you can determine whether or not they have a non-compressive radiculopathy by using the EMG nerve conduction study. Now, referring back to alteration of motion segment integrity, as you see in figure 15.3b, they have a very well-defined ways that we are to be able to calculate this loss of motion segment integrity. I encourage you to review this at length and practice on x-rays in order for you to become fluent in its procedure. Also, just keep in mind the alteration of segment integrity can only be found on flexion and extension x-rays. So you would do cervical, thoracic, and lumbar x-rays, including flexion and extension, and then you will basically be measuring for a loss of motion, and that could be a loss of motion could be an increase, transitional or angular motion, or a decreased motion. So that's something to keep in mind, not necessarily always a loss or a decrease, but a loss of integrity, either increased or decreased. And also, the motion of the individual spine segments cannot be determined by physical examination. That's why we use the flexion and extension x-rays. And it is defined in section 1B, 15.1b. Now we have Aquinas syndrome, which is a serious condition and a serious diagnosis, actually. It's manifested by the bowel or bladder dysfunction. One can have saddle anesthesia, which means they cannot feel or lack of feeling inside the legs from the calves up the thighs, buttocks, and down the other leg. Loss of motor and sensory function in the lower extremities. Usually there's a loss of sphincter tone on rectal exam, and you can actually have a diminished or an absent bladder, bowel, or lower extremity reflexes. I can personally attest that I have never seen this in my examination of individuals over the past 12 years. And finally, we have urodynamic tests. This goes in line with the Aquinas syndrome that we discussed in the last slide. But cystometrograms are very useful in individuals where the Aquinas syndrome is possible, but it's not certain. So you're trying to get a definitive diagnosis of Aquinas syndrome, a urodynamic test or a cystometrogram would be indicated. And a normal cystometrogram makes the presence of a nerve-related bladder dysfunction very unlikely. So this is a very good discerning diagnostic tool for the individual when you're trying to determine whether or not Aquinism exists. All right, well that includes today's presentation, and in our next installment we'll be exploring each of the 5 DRE categories and comparing and contrasting cervical versus thoracic versus lumbar, see the differences and see the similarities as well. And I'll also provide you with a number of examples of how to accurately place the examinee in the appropriate category. Some are very straightforward, others are a little trickier, and I think you'll be getting some insight in some of those examples. So again, I'm Dr. Chris Rapoff, and I want to thank you for joining me as we have begun dissecting the different DRE categories as we are trying to strive to be more accurate in our QME report writing. Until next time, thank you.